Hello, good evening, everyone. I am Dr. Sabiha. Today, we're going to discuss, especially a presentation about a case, oligodontia, syndromic versus non-syndromic. This was really interesting when I stumbled upon this case. The patient was referred to our clinic. Um, we've gathered as much as information we could, and we've gathered all here for our first part of this case. I've mainly focused on diagnosis, and on the second part, after the treatment is done, since it's an ongoing treatment procedure currently, when the procedure will be done, we will come in very comprehensive way. We'll discuss about the management. Today we will discuss about what is oligodontia. What is this? When I was studying for this case, to prepare this case presentation for you, I tried my best to make it as informative as possible, and I stumbled upon this. A true diagnostic genius lies in seeing the pattern that others miss. Often when patients come to us, we only see their teeth and do not go beyond um, the intraoral examination. Most of the time, we don't try to connect the dots, and we just stay within our boundaries and limits, which limits us to make a good diagnosis. So let's look at the definition. Schock van der Weyde in 1992 proposed the criterion that 6 or more congenitally missing permanent teeth, but excluding third molars, and since then this definition has been increasingly in use in dentistry. You can find a lot of definitions out there, but this one is in most use and defines it very clearly. So if we see, so this is oligodontia falls under tooth agenesis, a developmental defect in number of teeth. So hypodontia, oligodontia, and anodontia, these all fall under tooth agenesis. When we will call a case hypodontia, when there are tooth loss except third molars, not more than 6 teeth, and in oligodontia, it's more than 6 teeth, and in anodontia, all teeth are missing, which is extremely rare. So let's move on. Oligodontia, what are we dealing with? What is this? So tooth agenesis is the most prevalent craniofacial congenital malformation in humans. Up to 25% of the population may lose at least one third molar, but agenesis of other permanent teeth, excluding third molar, we'll always have to keep this in mind that when we are diagnosing a patient for tooth agenesis, especially oligodontia, hypodontia, we have to keep this in mind that we have to exclude third molars, because third molars most often it is like always missing most of the time, and it ranges from 1.6 to 9.6 in population. Mostly oligodontia and hypodontia are seen in permanent teeth, but in primary dentition it can also be seen. It can be affected. There are a few factors. There are environmental factors, there are genetic factors, but we will discuss about environmental factors and genetic factors. Primary cause is genetic factors. In environmental factor, we can see medical treatment, ongoing medical treatment like high-dose radiation therapy or chemotherapy during early childhood, especially when tooth buds are forming. Infections such as rubella or severe infections in early infancy, metabolic disturbances, local trauma can cause to missing tooth bud. So especially during the window of tooth development can lead to oligodontia. Genetic factors are the primary cause, especially mutation in transcription factor, MSH homebox 1 gene or PAS9, that is paired box 9 protein genes, have been identified in families. Recent studies show mutations in ectodysplasin A genes could result in non-syndromic oligodontia. And these are all the factors that can cause or lead to oligodontia. We will briefly discuss about oligodontia. What is this? I highlighted mostly on diagnosis. So let's quickly look at the classification. It's isolated or non-syndromic and syndromic. Isolated or non-syndromic means that tooth agenesis is the only finding. Patient is otherwise healthy. Systemic signs, there are no systemic signs. In syndromic, it could be patient has other systemic anomalies. From ectoderm, especially genetic links linked to genetics linked to these conditions are EDA or EDAR, EDA, ectodermal dysplasia pathway, and others. Um, Systemic signs, there are facial dysmorphology, ectodermal defects, cleft lip or palate, saddle nose, and supraorbital ridge should be prominent. Let's run down to case report now. For patient's confidentiality, we have kept the name confidential. Let's just assume that patient's name is A. He was 26 years old, a male. His chief complaint in his was he desired to have teeth. Patient had patient was psychologically very he seemed a bit depressed. He didn't want to smile, even though uh, he had this problem all his life. I wonder how he dealt with it through his 26 years of life. I took a brief medical history along with our regular ones. This is very important. I think making a good diagnosis depends on how detailed of a history you can take, because when in this kind of rare diseases, you never know what could come out, what your story or history could reveal. I've asked all of the medical history with along with if he has diabetes, asthma, any other physical ailment. Everything was negative, and as in he had none of those. But I've asked precisely these questions to exclude any syndromic association. That's what I was saying, that the best doctors don't just treat the symptoms, they uncover story. We had a very long session of history taking from this patient, because we were putting down the dots on the paper, and we were trying to connect those dots to lead us to a diagnosis. Extraoral clinical examination showed this. Even though some degree of physical signs were shown, but I think these were very common in being a South Asian. You can see this is the frontal view of the patient. Mostly from the lateral view, I think we can see a little protrusion or everted upper lip more than the lower. In intraoral examination, we've seen teeth. This upper incisors, central incisors, were permanent ones. From the X-ray, if you see, he had in the upper jaw he had two permanent incisors, central incisors, and two molars. In the lower jaw, he had two premolars. I guess these were first premolars, and two molars which were impacted, which is also a sign of oligodontia. Could be syndromic or non-syndromic. We couldn't determine, because patient were we couldn't run a genetic confirmative tests to exclude our diagnosis. So whatever my diagnostic reason for which lead us to make a provisional diagnosis, which is isolated or non-syndromic oligodontia, my reasoning was that all the evidence we've got that patient had more than 6 missing permanent tooth, no hypohidrosis, no excessive sweating, which are common classical feature of hypohidrotic ectodermal dysplasia. Facial dysmorphology. No striking abnormalities were found on the patient's facial features. So, which lead us to make a provisional diagnosis, which was isolated or non-syndromic oligodontia. But I will tell you what, diagnosis is not the end, but the beginning of a practice, which Martin H. Fisher said, and I believe so as well. So we did our management. I'm going to discuss about it in brief because it's going to be very detailed in on our next part. So stay with us, stay tuned with us. Initially, it is said that in textbooks and in journals, you'll find that dental implant is the gold standard for long-term stability as a treatment plan. However, the gold standard for long-term stability. However, because the teeth were never present, the jawbone in those areas were syntropic. According to our treatment plan, we decided to go for fixed prosthesis, zirconia, and raise the vertical dimension of occlusion. We always involve digital dentistry, digital outflow that makes it more precise, that makes it more easier for us to um, make an prosthesis or make analysis or do the analysis of the patient's condition. Um, this is our 3D. First, we took in preliminary intraoral 3D scan for the purpose of making a transient prosthesis. And then we did mouth preparation, included, he had some degree of calculus, we removed those, and then we did a vital tooth preparation on the lower tooth, on the deciduous tooth as well. And we did a root canal treatment to upper central incisors, permanent incisors that he had on these two. And we did vital tooth preparation. We built up these molars, and for support, we've prepared those. Sorry. And this is it. Now the treatment is ongoing. When we will be done with our preparation and the treatment, we'll discuss the treatment plan and everything in details. So what I want to say, the takeaway from this case presentation, I think, look beyond the teeth. Okay, as seen in this case, that missing teeth can be only the tip of the iceberg of a disease. Thank you for staying with us. Thank you for being patient. I hope this is going to be informative, and further, it's going to be more detailed in the next part about the management, the treatment plan. So stay tuned with us. Thank you.